Hi, Jamie. How are you doing today?
Very good. Thank you so much for having me, Barry.
Well, it's really great to have you. I know we're going to have a really good session today. I'm going to jump right in and ask you a question about decreasing reimbursement rates and that provider organizations are pressured to efficiently manage their revenue from deployment of their fixed assets as well as their staff. The OR suite is one place that organizations are looking to make more efficient, particularly in this age of COVID-19. Why is the OR suite such an important place to look to increase efficiencies?
Well, you know what? What I've found is that almost all health systems have three overarching goals, right? Their goals are to save lives and improve quality of life for patients, to increase their revenue, and to decrease their costs. And most of the time, those three things seem in opposition. The one thing that I know of that can really affect all three is OR efficiency, right? We don't have surgeries unless we're trying to save lives or improve the quality of life of the patient. The more surgeries we can do, the more timely we can do them, the more patients we can help. And over 95% of elective surgeries are profitable to the hospital. I have never worked with a hospital where the peri-op suite is not the most profitable unit of the hospital, so it certainly checks the revenue box. And finally, any unused time in a staffed operating room is extremely expensive to the hospital. The highest cost in the hospital is the peri-op suite. One of our clients recently told us they value it at $310 per minute. Once again, if we can decrease that amount of time that the OR room is sitting empty, we can reduce cost as well.
That's very interesting. $310 a minute. That's a lot of money. Um, what efficiencies opportunities exist in the OR suite? Can you describe some of them?
Yeah, so the fundamental goal, right, is to increase the amount of time that the OR room is full and decrease the amount of time that the OR room is empty. It's that simple. And to do that, we can do things like schedule better so that we have a case scheduled for all the time in the OR that we're open. And we can reduce cancellation rates so the beds are fuller. And we can reduce the time between cases so that the rooms are empty less. We can start on time so the beds are empty less. And we can move around and schedule the most efficient way really to do the most cases and accurately predict how long those cases will take to squeeze the most surgeries in the rooms. Once again, the whole goal being to have the patient bed full as much as possible and empty as little as possible.
So, what steps should organizations take to make the OR suite more efficient? What are the things that they can do?
Right. Well, certainly as an analytics person, I think that the fundamental goals is that you need to be data driven because you really need to know where your opportunities to improve are. And to know where my opportunities to improve are, I have to have data like what is my utilization, what are my blocks, what is my on-time start, etc. And I can find out where there's opportunities. So some of the things you can do is you can move around schedules. Maybe you're doing 12 hours of surgery one day and 4 the next, and we could smooth it out to 8 each. You can see which types of surgeries are overestimating how long they're going to be in the room. So if you have a surgery that's saying it's going to take 2 hours and it takes 1, then we have 60 minutes that we could have done something with. But we won't know that unless we have the analytics and the information in the way that we can consume it. So the whole idea is to get the information, present it to leaders in a way that it can be consumed, and use it really just to schedule cases better and to optimize the time in between cases and the starting of the cases.
So, what do organizations do now when they look at blocks? Or do they have a particular standard book that they look at? Is a national standard? How do people decide how long a particular surgery is going to take, and how do they block out that time?
Yeah, so there's a couple of different things there. So blocks can be done a few different ways. You can schedule them by surgeons, or you can schedule them by services. And then a hospital will have set up a workflow to release them. If, for example, you were, going to be at a conference this week and not do your surgeries, but you still have to execute that workflow. So the challenge is we don't want a situation where one provider group, say orthopedics, is consistently having to go way beyond the end of the day and have people working overtime. And then maybe we have Tuesday afternoons as ENT, and it's usually empty, but ENT is doing a lot of cases on Thursdays. So there's a lot of opportunity to move those sorts of blocks and schedules around. As far as case duration, the first thing we need to know is which cases are we accurate on and which are we not accurate on. And a lot of those default values in the system are templated by the EMR. And they might not really apply to exactly how that surgeon works. And so we could look and say, if we've done a fairly repeatable thing, let's say we've done a colon biopsy and we've done it, 50 times, and all 50 times it completed within 45 minutes, but the default says 60, then we need to lower that, right? They don't want to underestimate the time because that will kind of back everything up and mess up the schedule. But if they overestimate the time, that's really just as bad because then you're going to end up with empty times in those rooms.
I would imagine you could do analytics on not only the types of surgeries that are done, but the individuals who do those surgeries. And I know from my own experience working in patient safety and quality that understanding the length of time of surgeries based upon the individual surgeon is important as a quality metric. What do you think about that?
Yeah, absolutely. So we spend a lot of time to make sure to attribute all of our information to surgical departments, to surgeons, to types of procedures, to types of anesthesiologists, to types of anesthesia. All of these sorts of things can play in. And it can make a big difference. Like if a surgeon is trying to run two cases that overlap in two separate rooms. There's a lot of different sort of examples that can hinder that. The other thing we've seen a lot of success with recently, improving this efficiency, is looking at, do these surgeons' cases require specialized care? Do they require aftercare? And if not, during COVID especially, could we maybe move them somewhere else in our health system? Do we have an ASC or a community hospital where maybe we can move some of our cases to get even more capacity and make sure our most critical patients have the best access to them?
What metrics should organizations track to understand the success of their efforts in this area?
Yeah, so obviously at the very highest level, we want to track our number of cases and our number of minutes in the room. That's fairly obvious, right? Our goal is to do more surgeries and to have more minutes in the room. Then we want to track our utilization. We track that two different ways. So we track for the blocks that we were scheduled, how much did we use them? And then for our staffed rooms, how much did we use them, and for hours of the day. So we can look and see, if we're consistently going to 7 p.m. and we're only staffed to 5, maybe we can increase that. And so at the highest level, we want to improve utilization, and those are the metrics that drive that. Then we have trend metrics and distribution graphs that we utilize really for each metric. So we want to know, what is our percentage of cases that start on time? What is our accuracy rate for predicting case duration? What is our same day cancellation rate, our previous day cancellation rate? Really, any efficiency metric, we're going to try to both trend it and look at the distribution, realizing that being 5 minutes late and being 30 minutes late are not the same thing.
So we know that staffing makes up a large share of the cost a hospital has to support. Can you provide some insight on how to better manage staff to make them more efficient, particularly in the OR suite?
Yeah, absolutely. So we define budgets by location and surgical suite, and those budgets are really our nursing staff. And so we'll say, for example, that we have a client that says there's 20 during the day, from 7 to 3, and then from 3 to 5, there's 18. In the middle of the night, there's 2. And it's really important to get that level right? So we don't turn cases away because they're elective and we're not staffed. But at the same time, we're not paying nurses that aren't needed, and we're not calling in overtime because we didn't realize they were needed, which is why it's so important to reduce variation in utilization so that we can really predict that well. So fundamentally, we want to get the staffed hours that were open right and utilize those as much as possible instead of having to bring in extra staff. The other thing that we really look at a lot is anesthesia staff. So some peri-op solutions kind of ignore anesthesia, and that's can be problematic because anesthesia is used in every OR service, and it's also used in procedural areas like in obstetrics and endoscopy. And sometimes the same anesthesiologists support community hospitals. And so we might have availability of OR staff, but if we don't have availability of anesthesia staff, then that's a problem that we need to solve. And if we do have availability, but we're pulling it away from other procedural areas, then we're causing traffic jams and problems outside of our suite that really still need to be optimized to be efficient across the health system.
Well, we talked a lot about the OR suite, but once patients leave the OR, they move to the surgical ICU or even to the floors. How does what is happening in the surgical ICU or on the floors impact what happens in the OR suite relevant to efficiency?
Yeah, so there's a couple of things there. So one thing we haven't touched on today is PACU border times. And I think that's really important, right? So the quicker I can move a patient out of the PACU and into their bed in the ICU or the inpatient floor, then not only do I not need that staff anymore, but I can put another patient there. And so if I have this kind of backfill where patients are waiting in the PACU for ICU beds, then I have people waiting in the OR for PACU beds, and then I can delay surgeries. And so we've seen a lot of focus recently, especially with COVID, on occupancy and on patient flow across the hospital. And so one thing that our hospitals or the health systems that we work with really want to focus on is increasing the percentage of their cases, the percentage of the patients across the whole hospital who are there for medical reasons rather than surgical, or surgical rather than medical. So their goal is to increase surgical patients and reduce simple medical patients. But we're not going to turn medical patients away, right? We have an emergency department. We're supporting COVID. So how do we get surgical patients in to increase that percentage? Well, we really need to understand what occupancy we're going to need and how many patients are already there. So we look at ICU occupancy by day of the week, by time of day, expected length of stay for the patients there, expected arrivals from transfers and ED and OR. And we really look at what is the occupancy that we have available for surgeries, and then what is our elective schedule and our add-on rate, and what occupancy will we need. And a lot of times health systems, if they feel the occupancy is going to be greater than they need, they don't actually turn patients away. They open high census beds, and they still do the surgeries and get the patients into the ICU. But the earlier you can know that you're going to need to do that sort of surge occupancy, the less expensive it is. And you really want to be right. You don't want to think there's going to be a surge and be wrong. So it's all around moving the patients out of the OR and into the beds efficiently and predicting the occupancy of those beds by unit and type of bed.
Well, we talked a lot about metrics that are used in these dashboards, but we didn't talk about who should obtain these dashboards and how they might use them. Can you shed some light on that?
Yeah, so we actually have quite a few different types of users. So we really want to get down to the surgeon level, not just management. So we like surgeons to be able to look at the information about their surgeries, about other surgeons in their service. so that they can learn how to self-improve and where the opportunities for improvement are. So certainly surgeons, directors of each type of surgery, so your cardiology director, your neurology director, then the people who do the scheduling and the OR directors. We do have an executive level dashboard that we give to people like the COO and the CEO and the director of finance. And lastly, we've gotten a lot of movement with the nursing managers, and especially combining that with, we have a capacity management team at 2 of our hospitals that are looking to do that patient flow into the ICU and into the med surge floors as efficiently as possible. And the better the communication we have between the OR floors doing the anesthesia recovery and the inpatient floors receiving that patient and doing their more long-term care is really, really important.
Well, you talked a lot about dashboards for the OR suite. What about the procedural suites, such as the cath lab or interventional radiology or even the endoscopy lab? Do the principles and metrics and to some degree the dashboards fit within those labs, and how could they potentially impact them?
Yeah, absolutely. So almost all of our metrics we do support for those procedural areas: cath lab, electrophysiology, endoscopy, and interventional radiology. And there it's almost more important because they're going to do a higher volume per room, but their cases are shorter and there's less revenue. So it's all about efficiency and staffing them exactly right, because most of those units aren't open 24 hours a day, or they're not staffed 24 hours a day. So we really look once again at staff room utilization and at efficiency metrics and what our volumes are and how we can reduce that variation. And we found a lot of success. And once again, the anesthesiologists are often shared. So I recently did some work for endoscopy that shares their anesthesiologist with periop, and also a cath lab, which actually shares 2 of the rooms with periop. And so it's really important to look at the system as a whole. And if we ignore those procedural areas, we won't be able to optimize that anesthesiologist time or those hybrid room times.
Jamie, thanks so much for spending time with us today. I think we learned so much about making the OR suite efficient, but in addition, several other parts of the organization to make them more efficient, particularly the labs you just talked about. Additionally, you shared a lot of information how it's important to share analytics with multiple people in an organization to get everybody to be informed in their decision making and how they move forward. So thanks again for spending time with me today.
Absolutely. I really enjoyed our conversation.